Thank you. Representative Christiana.
Thank you, Mr. Chairman, and thank you for your testimony here this morning. Oftentimes we have many fights, especially in this committee, over one word, and those words are really important. And a lot of this conversation on this topic has been about supervision versus collaboration. I want to talk about the importance of the hierarchy. Currently, do nurse anesthetists work for you, the anesthesiologist? Do they directly report to you?
They do. As a supervising physician, we're in charge of what happens in that room.
And so in those split-second decisions, those high-stress environments, in those critical stages, you're tasked, you're also probably liable for making those decisions. Can you talk about the importance of having to be decisive in those moments, and can you maybe just talk about the decisiveness that it requires and how important supervision is in those moments, and the hierarchy is in those moments, rather than a collaboration, which could, I think, blur the hierarchy and who works for whom and who's the ultimate decision maker?
Yes, thank you. Within supervision, I am the team leader. So when I am supervising, I am the leader for the anesthesia team in the room. So when something does happen, it is at my discretion for the direction of what we're going to take, so I'm able to make those rapid, quick decisions and direct people. If it was more of a collaborative role, you could potentially have a little bit more of a wishy-washy kind of what next step should we take? Well, maybe this should be the best step. And there's not really a lot of time for discourse when things go wrong. So you really need to make a decision and act upon it right away. We're thinking the whole time we're making these decisions, but it is a very rapid, fast action. Think of it, we always talk about how codes are managed in the hospital. Within the ACLS protocol from the American Heart Association, they identify that there must be a team leader to lead a code effectively. And we watch videos all the time of the code that has a team leader that's run effectively versus the codes that are a little bit more messy, where there's really not one true leader and things can go wrong. Similarly, we can think of ourselves kind of as the pilot of the plane. When something happens, we're the one that makes the decision. We're really taking ownership for the patient's care from the moment we meet with them in the pre-op area until the recovery period when they're leaving the hospital, and even beyond sometimes. If something bad happens, we're the one that goes and talks to the patient's families and follows up with the patient. So it really is our responsibility, and it's very important to have that distinction that we're the leader and the supervisor. We're working together as a team, but it's important to be the team leader.
And with that responsibility, liability would unfortunately also fall on the physician as well, correct?
Absolutely. It would be, I am the one liable when I'm supervising a room. Any actions that anyone that is practicing under me will be, I'm responsible for. So, for example, I was working with a CRNA, and she accidentally chipped a tooth. She felt very bad about it. We have a whole protocol to deal with that. It's not something that's unheard of when you're placing a breathing tube in anesthesia. But I was the one who went and talked to the patient afterwards about that chipped tooth and the follow-up, and I've been involved with her care and her seeing the dentist and getting that tooth repaired. So even though I wasn't the one who chipped the tooth, I was supervising her and taking responsibility of the care that she was giving. So that ultimately fell up onto me.
One final follow-up, Mr. Chairman. I do think it's important for us to allow for flexibility. And when you're writing a one-size-fits-all healthcare policy, it's pretty difficult when you have the 5th largest city in the country and some rural areas that may need additional flexibility. And I've heard you talk about the flexibility of operating the number of operating rooms that you may oversee. I think I heard you say a hospital could set up a situation where you have to oversee 4. They can go to a maximum, but they choose to only have you oversee 3, sometimes 2, but they don't always go to the max, if I heard you correctly. As well as this bill and this regulation provides additional flexibility in that an operating physician could supervise the administration of anesthesia, correct?
I think it's very important. It doesn't say an anesthesiologist. We'd prefer it to be an anesthesiologist supervising anesthesia, but it does say an operating physician can do that, which is different than New Jersey. New Jersey requires supervision to be by an anesthesiologist. So we're not trying to change that. We think that we need at least a physician there, and it's a very small percentage of hospitals in Pennsylvania where that happens, but it does allow for that hospital that cannot have an anesthesiologist present.
I guess my point is that even though we grant that flexibility to hospitals currently, they choose not to eliminate the anesthesiologist from the equation. They have the flexibility, but they choose for patient safety, I would think would be the number one reason to have you in the operating room and supervising, and I think that's appropriate public policy that provides an appropriate level of flexibility, but we have seen hospitals not want to stretch all the way to the extent of the flexibility we provide, which I think is responsible. And lastly, this regulation only applies to operating rooms. It does not apply to surgical centers. So I think that is another example of the flexibility that we provide, that we're not saying that in every situation where an operation occurs, there must be an anesthesiologist. We provide adequate flexibility. In your opinion, do we provide adequate flexibility to meet the diverse needs of Pennsylvania operating rooms and the administration of anesthesia in a pretty diverse state?
I think we do. As we said, 99.7% of the hospitals have an anesthesiologist there, so it's a very small percentage that do not. 99.8% of the surgeries performed in Pennsylvania hospitals are performed in those operating rooms. So there's a very small percentage, 0.2% of the hospitals or the surgeries don't have an anesthesiologist present, but they have the operating physician there. So I think we are covering all those opportunities and not leaving anything out, even in the rural areas.
Thank you, Mr. Chairman. Thank you again.